Hello, and welcome to Looking at Lyme. Today's conversation is with Dr. Tim Cook. He's an internal medicine specialist who has spent decades helping patients with complex illnesses. Dr. Cook worked abroad with the Canadian Armed Forces, and he has been the physician for multiple officials at Rideau Hall. Looking at Lyme is created by the Canadian Lyme Disease Foundation. I'm your host, Kim Cairns. In today's episode, we hear how medicine is evolving to handle Lyme disease and learn more about an upcoming conference for medical professionals about tick-borne diseases. Hi, Dr. Cook. Thank you for joining us. We appreciate your time.
My pleasure. Thank you for inviting me to speak with you.
To begin, can you share with our listeners where your interest in Lyme stemmed from?
Well, I was a Canadian Forces medical officer for a total of 20 years, initially as a general duty medical officer with the dubious rank of Captain Cook, which was 2 bars, not 4 bars. In any event, eventually I was able to do internal medicine training, and because the military likes their internal medicine specialists to have skills in a number of subspecialty areas, most importantly, tropical disease, I was able, with great good fortune, to go to London, England, to the University of London School of Tropical Medicine and have a diploma, and then ultimately from the same school, a master's degree in public health. And one of the written theses I undertook was around vector-borne disease, and more particularly malaria, which is transmitted by mosquitoes, of course. But I did learn a little bit about tick-borne disease during that tropical course, and subsequently had deployments with the Canadian Forces to rather hot, sticky places in the world like India and Haiti. Spent 3 months there, and of course was able to apply tropical medicine at the coalface. I must admit that when I retired from the military in 2003, I had just started to have some experience with people in the forces who were sick with unexplained illnesses. And I had 3 or 4 of those patients that were actually posted and living in places like Kingston. And it became clear to me that they actually had Lyme disease, which 20 years ago was much less on the radar. And frankly, I didn't know that much about how to handle them, but I did know that when I gave these patients antibiotics, they seemed to do a whole lot better. Just prior to retirement, I had a little bit of a bun fight with the then Surgeon General about the existence of chronic persistent Lyme disease, which remains, as you may know, controversial. But I must say I never expected that my training in the Canadian Forces as a tropical disease specialist would actually bear fruit in this rather temperate country climate. But of course, global warming is seeing to that.
Mm-hmm. Yes. Yes, climate change is a factor in virtually everything we're living through right now.
Sad, but true. And the reality is, and the prediction is, that ticks that can transport and transmit these rather nasty infections, and several of them are moving northward at a fairly brisk clip every summer. In fact, they move up. And the prediction is by somewhere in the 2030s, mid-2035, we are likely to be able to get a tick-borne disease as far north as the northern part of Ontario.
Yes. Yes.
Right now, to be honest, it's clear that it is prevalent as far north as sort of Algonquin Park.
Mm-hmm. Mm-hmm. Can you tell us a bit more about how your background in tropical medicine prepared you to better understand Lyme and Lyme co-infections?
Well, I think the bigger picture as well, Kim, is that internal medicine specialists, both in community hospital settings and in academic hospital settings, seem to be the go-to for patients that are undiagnosed and complicated and complex. And I will say that even as far back as my military career, I was part of a group following the first Gulf War that began to investigate Gulf War syndrome. And we started a clinic which kind of segued to be a chronic fatigue clinic. because it wasn't at all clear what was the underlying cause or causes of folks returning from both the First and Second Gulf War with rather chronic unexplained symptoms. And so what I began to realize is that as a conventional internist, certainly prior to my retirement from the military, I didn't have enough tools in my toolbox to really understand and help those people. And so round about 2005, on conclusion of my master's degree in public health, I started to do some additional courses and training. Some of that included, in relation to those few patients I started to see before I hung up my uniform, attending conferences like ILADS, the International Lyme and Associated Disease Society. They have an annual conference that moves around the world and is obviously quite relevant to tick-borne illness. Also, I took courses in functional medicine and integrative health, and ultimately decided, after dabbling in conventional internal medicine on the ward at Mount Sinai Hospital in downtown Toronto, where everybody there was dying of things that were preventable, which bothered me immensely. I started my own clinic in 2012 called P3 Health, for personalized, participatory, and preventive. I started it with an osteopath and a couple of naturopaths and a psychologist, and that thing grew to be a behemoth of 7,000 square foot clinic with 20 odd practitioners in it. And most of that rise was in relation to trying to meet the needs of people who had fallen through the cracks of conventional medicine. And in fact, folks with tick-borne illnesses, especially if they show up at a conventional specialist office, most importantly an infectious disease specialist, and say, I think I have chronic Lyme, are almost immediately dismissed as being mentally unsound. Unfortunately, the average number of specialists that my patients would see was 8 to 10. Rheumatologists because they had terrible body pains and thought they had arthritis. Neurologists because they had all kinds of neurologic symptoms. General internists because they deal with chronic complex unexplained patients, but they couldn't solve them either. And ultimately, we developed a sort of systematic approach to helping people that seems to have worked quite well. And we got that reputation, even though I really didn't advertise this very much. But news travels fast on the internet, it seems, and we were getting pretty much inundated. The supply of caregiving did not nearly meet the demand and still doesn't, sadly, and it's getting worse in that regard. So I've already digressed from the question, Kim, my apologies, but I think having the military experience of understanding tropical disease and that vectors that transmit these diseases are important. They're global. They're increasing due to both globalization and global warming. That was also all important. I think having a master's degree in public health that the military sponsored after my retirement was really helpful, because it put into perspective that care is not just about, high-tech organ transplants and MRI machinery. It's a lot about listening to patients and getting back to grassroots of primary care and trying to understand what they're really telling us and not dismissing them if they don't fall into a kind of conventional rubric.
And I just have to comment that I love and admire that integrated approach. It's a one-stop shop that addresses a lot of unknowns for patients. And they're going to get a quicker response because everybody's gathered in the same place.
Absolutely. And part of the stepwise approach to helping these patients that I kind of learned on the job was not to throw antibiotics at them in the first instance, even though we thought, oh, you have evidence of chronic persistent infection, therefore antibiotics are likely to be helpful. And for some people, they definitely are. But much more important at the grassroots, so to speak, is to optimize the immune system so that you can engage your own innate ability to heal and allow your immune system to deal with these infections. And almost everybody we see that have these problems have immune issues underlying it as well. And so ignoring those and just focusing on the infection with, high-powered combination antibiotics is failing to meet the kind of holistic needs of an individual. And so what we learned was folks need to have a really optimal diet. And for many people, that is dramatically changing the standard American diet that we're exposed to. 75% is carbohydrates, highly processed foods. Just getting people to have a healthy plant-based whole foods, ideally carbohydrate restricted diet, actually improves symptoms 50% in many people. Getting them to pay attention to their symptoms in ways that are mindful and mindfulness-based stress reduction programs and other kinds of tools like wearables that enhance stress management, lowering our sympathetic and fight, flight, freeze responses to things. Those are critically important. A bit of gentle physical exercise, being active is important, although many folks with these illnesses can barely get out of bed, let alone exercise. And, then we do some high-tech things that I think are important to emphasize, one of which is to do genomics. And in this case, it's understanding individuals as individuals and treating them with the personalization aspect of, well, what is your genetic blueprint that is also contributing to these problems? And what we found, for example, is a high percentage of people who end up with chronic complex illness are having a genetic endowment of detoxification pathways that are very suboptimal. They don't clear toxins from their fatty tissues nearly as efficiently, and that can be genetic. They don't methylate properly, which has to do with B vitamins. But methylation is a critically important detox and anti-inflammatory pathway in our cells. They don't antioxidize very well. And we can look at all kinds of genes that help us understand that that is a problem. But more importantly, what are the specific interventions that can turn around and work around those problems? And at the end of the day, there isn't a one-size-fits-all and should not be a one-size-fits-all approach to this. Everybody is individual. And so we don't give the standard 200 supplements that many people get from a integrative or naturopathic clinic. We give the supplements that have been shown in your blood work to be needed and in your genetics to be needed. And often that is quite ameliorative of a lot of the symptoms, even if we have not yet treated the Lyme disease per se.
It's fascinating, but it shouldn't be fascinating. This is the way medicine should go, right?
This is what we call functional medicine at the coalface, which is rooted in understanding the foundations of illness from the upstream perspective and from the individual genetics and individual environment, lifestyle, etc. perspective, as opposed to a rather conventional approach of, oh, here's a symptom, here's a Band-Aid for that symptom. What's your other symptom? Let's give you something for that and move on. And sadly, most of the specialists that these people see are much more interested in the effect than the cause, because finding the cause is often difficult. It may be outside the scope of the OHIP system they work in. There may be special tests that you have to access that are private or outside of Ontario. Ultimately, they just don't have the time or the interest or the energy to go upstream to find those causes and deal with them. And so people get labeled with an illness that are really based on the symptoms they have. Oh, chronic fatigue, you're tired. Oh, fibromyalgia, you got a lot of aching in your body parts. Oh, you've got multiple chemical sensitivity or environmental intolerance or mast cell activation syndrome. All of these things are labels that don't actually identify or address or diagnose what triggered all this off, because most folks aren't born this way, they develop it. One of the things, for example, is co-occurrence of problems related to the immune and the other factors I alluded to. For example, at least 75% of Lyme patients, when we look hard, have mold exposure and mycotoxicity. Mold, of course, is not rare. Almost half of the basements in Ontario that are intruded with water have mold in there, and most of us have exposures to mold. There was an article published in the British Medical Journal a couple of years ago from some epidemiologists who looked at the global state of vector-borne disease and came up with a mind-boggling estimate that 14.5% of the world's population have Lyme disease. That's 1.2 billion people. Well, most of them don't know and don't care because their immune systems are robust enough to contain and control that Lyme bacteria, so it's not causing symptoms. And this is not actually new. Conventional medicine has dealt with similar situations, latent infections. Tuberculosis is a classic one. Syphilis, which of course was a scourge of Middle Ages, is actually a kissing cousin of Lyme disease. They're both spirochetes, corkscrew-shaped bacteria. So latent syphilis, well established. For most of us who get chickenpox as children, we think after the rash is gone that you're done with it, except that virus hangs out and is still alive. Your immune system contains it until it doesn't, and then you get shingles. So this is not unique, but it's just not conventionally accepted that Lyme behaves this way. And so what we're sort of finding is people who have all of these symptoms associated with Lyme bacteria, they're in that small 5 or 10% of the world who got the infection because ticks are everywhere, giving people Lyme, but their immune systems are under the weather and not working properly for various reasons that then collude to give them symptoms. And so the first principle is identify what are the things impairing your immune system and optimize those. And frequently mold toxicity or mycotoxins are a big part of that. And they're also things we can work around and fix. So it's a process that takes time and energy and effort. And for folks that have been sick for, decades, we don't turn them around and get them back to full function in a week. It may be a year or 2 years, but we do that for most of them.
How are medicine and research evolving to meet the needs of Lyme patients?
I think the attention to the scourge of tick-borne illness is increasing. So there are conventional researchers that are putting their attention to trying to improve the diagnostic test capacity, improving our understanding of how to treat these infections. There are conventional publications that have confirmed for at least 8 years that Lyme bacteria has this behavior of changing its form from a cell-walled spirochete into a non-cell-walled tiny little thing that goes and essentially invades and lives inside our cells. So it has an intracellular form, which is kind of what the microbiologists call a stationary form that doesn't do very much. It doesn't reproduce and it doesn't grow. It's just kind of hanging out. Unfortunately, the conventional antibiotics that we use primarily work by blocking a bacteria's ability to make a cell wall, which it's not doing, and or block it from reproducing and growing and making more bacteria, which it's not doing. So this is the other part of the problem, is that if you just say, oh, you have Lyme, here's antibiotics, it's not very effective for dealing with the chronic symptoms. And often people will take the antibiotics and A, feel worse, B, not have sustainable improvements, or C, when they stop the antibiotics, all the symptoms come back because the persister form is still there. So this downstream approach to this, which is still kind of conventional, is not particularly effective. The upstream approach in terms of identifying what are all of the foundational contributing factors that render the immune system suboptimal, and then dealing with those. And then there's, I would say, other steps before we get to the complex combination of antibiotics, which I still use, but much less now than I did 10 years ago. For example, peptide therapies have become a really big part of our practice. And sadly, these are outside of the scope of conventional doctors, mostly because they're, quote, not approved by Health Canada or FDA. We get them from a good manufacturer in the US. They say for research purposes only. But I will say that these peptides have been studied and are known to be safe and effective for at least 2 decades, most of them. And so a stack of peptides that we call our Lyme stack, which are working on the one side to improve the immune system. These are what are called thymosin fragments, thymosin alpha 1, thymosin beta 500, for example. And on the other side of this kind of immune versus infection teeter-totter, the other side is how can we engage the innate immune system of humans? And there is a peptide called LL37, which does that. And then there's another one, the fourth one in this mix, called body protection compound 157, BPC 157. These are all given as subcutaneous injections, typically for a 6 to 8 week pulse. And we have found these to be hugely helpful for many patients, and obviously are much better tolerated than antibiotics, which are a double-edged sword at the best of times, because in the process of killing Lyme and tick-borne infections that are co-infections, we are unfortunately also wiping out good things like our microbiome. And that requires a very delicate kind of tightrope.
Right. Which takes time and energy. And when we have a 15-minute appointment with our doctor, we can only talk about one issue.
Correct. And that brings me to the one thing that I would love to have every doctor in Canada, or in North America, on their desk is a questionnaire developed by Dr. Richard Horowitz, whom I've studied with and I have huge respect for. He is also an internist. He is practicing out of Rhinebeck, New York, mid-upstate New York. A stone's throw, if you will, from the Lyme, Connecticut, which is where the name of this bacteria comes from 1982. So it's not limes with an S. It's not Lyme, L-I-M-E, like the citrus fruit. It's L-Y-M-E from Connecticut. In any event, he has had something like 15,000 Lyme patients, roughly 4 to 5 times the number I have, but I'm sadly the highest number in Canada. Richard came out with a questionnaire that he has validated and published in 2 peer-reviewed journals. And ultimately, for people who have multiple system symptoms and classically very profound fatigue, migratory arthritis or joint pains and muscle pains, so pains that move around the body and come and go. Most importantly, neuropathy that's migratory, so numbness, tingling, burning that moves around the body and comes and goes, which isn't MS. In fact, in the world of neurology, the only thing that causes migratory polyneuropathy is Lyme disease. So Dr. Horowitz rates that with a heavier weighting. If you've had problems with your gastrointestinal tract, if you have evidence of autonomic neuropathy with postural orthostasis, your blood pressure drops when you stand up and you can hardly walk around because you're lightheaded. If you have balance and dizziness problems, if you have brain fog where you can barely think anymore, these are some of the classic symptoms. Being tired but wired, not being able to sleep properly, developing this sort of acute insomnia when you get it, having mood changes and mental health changes. In somebody that's got all of these symptoms, and this questionnaire captures those with a scoring system, you can definitively diagnose Lyme disease just from a questionnaire without needing expensive blood tests at all. In fact, he has shown that somebody with a score over 60, and by the way, the maximum you can get is 150, and most of my patients are in the hundreds, but if you're over 60, your positive predictive value for having Lyme disease or tick-borne illness is about 95%. So this is a very important tool because otherwise you end up doing what is costing our health system dramatic amounts of money. Is the family doctor goes, oh my God, you must have MS. You go to a neurologist. They rule you out by doing MRI scans and lumbar punctures and a whole whack of stuff. Say, oh, well, we don't think it's MS. Go back to your family doctor. So then your family doctor sends you to a rheumatologist because it must be a rheumatologic disease because you got all this pain. No, that doesn't work. So then you go back to a neurologist for your brain. Maybe you've got dementia. Oh, no, that's not it. Then you go to an internist who's trying to figure out all these complex things and they can't figure it out. And an infectious disease specialist pretty much throws anybody who thinks they have chronic Lyme out of their office. And then the last referral, sadly, is to a psychiatrist. So most of my patients come in on antidepressants. They say, my psychiatrist didn't really think I had a mental problem, but nobody could figure me out, so I'm on antidepressants. And so then we take our approach, and typically within a few months, people are at least 50% better. And so I think the conventional approach to this is just wrong. It is designed not to meet the needs of these kinds of patients. And sadly, there is evidence that the conventional system is not diagnosing roughly 90% of folks with these illnesses correctly. And there's something around 90 to 100,000 people in Canada, ballpark estimate, getting this disease every year. So the numbers are getting to be astronomical and, as I say, an unsustainable cost to our health system for assessing inappropriately all of these individual system symptoms.
So how do we get Dr. Horowitz's questionnaire into the hands of more doctors?
Well, that's the $69,000 question. And to be honest, after years of working in this domain, roughly 15 now, and being frustrated that I seem to be the lone wolf, and also I'm 64, so the future of a career is, I'm in my denouement. So how can I help educate the medical population? And I think the time is now because it is increasingly on the radar of many doctors. I think increasingly they are becoming aware that they need to handle acute Lyme so it doesn't become chronic, and chronic Lyme is actually a thing. And so on that basis, roughly 8 months ago, I connected with Can Lyme and said, I've had in my mind the idea of a medical conference that's focused on this, that has a Canadian perspective and Canadian context, because there are obviously many conferences around the world, including ILADS I mentioned and others, but never one that's been purely a Canadian for Canadians. And how can we kind of put something together that's very helpful and engage not just medical doctors, but naturopaths, many of whom are the first line of defense because a lot of patients end up in their care having fallen through the cracks again of conventional medicine, nurse practitioners, physician assistants, anybody that is out in primary care, especially, and I would say emerge docs are important here, family doctors are important here. How do we get some of this into their hands and diffuse some of the controversy around it and diffuse some of the misinformation around it as much as we can? And I think the upcoming conference, being the first, will have perhaps some growing pains around getting the word out. But if we can get even 30 or 40 people to show up and engage with this group of very experienced practitioners and academics who are going to be speaking, then I think we will have a good chance at getting this education out there.
Appreciated your sharing that questionnaire with us. We're going to include a link to that in the show notes, as well as your conference.
Great. Thank you. And of course, patients or people who are suffering or experiencing a lot of symptoms in a lot of areas that came on suddenly and are unexplained should also engage and do this questionnaire, and then they can bring it to their primary care doctor and say, hey, I think this is what I have. And the one thing that I will comment upon is that our diagnostic tools that are in the public health system in most provinces are definitely suboptimal. There are researchers trying to improve these tools, but right now what we have is public health surveillance tools that are designed to be very close to 100% specific, meaning if you're counting the heads of people in a country or in a province that have a disease, you want to make sure that you establish with nearly 100% certainty that they actually have the disease. That's what specificity of a test is all about. There are no false positives. The problem in medicine in general is if you raise the level, if you will, the bar for diagnosing something so high that it's 100% or near 100% specific, the sensitivity, i.e. the false negative rate, goes up. And so the sensitivity of the testing we have in our public health system is, in some estimates, as low as 15 or 20%. In other words, people who actually have Lyme disease who do the testing are told it's negative about 80% of the time. That is a huge disservice to individuals. From a public health surveillance perspective, at least they can say, well, 10 years ago, the number of Lyme cases was 800, and now it's 8,000, and every one of them 100% certainly had Lyme. Oh, it's going up, and that's pretty much the data.
Right.
But it's not very good for doctors to make those diagnoses across the desk using those diagnostic tools. In particular, I'm talking about the Lyme serology, which is a two-step test. These are looking for antibodies. What's interesting in general is if you ask infectious disease specialists about intracellular bacteria, ones that like to live inside our, especially our immune cells, can you look for antibodies? Well, no, because they actually evade that part of the immune system. You don't make antibodies very much. And this is one of the major problems. If you ask, for example, how do you diagnose tuberculosis around the world? Every infectious disease specialist will say, well, you don't measure antibodies in the bloodstream because they don't make antibodies, but you still have TB. How do you diagnose that? It's a very different mechanism, looking at cell-mediated immune responses, whether your soldier cells, if you will, are activated to do hand-to-hand combat with the infection. That's what you look for. You don't look for the B lymphocytes response, which is making antibodies, because there aren't any. And so that's one of the other problems of Lyme testing. I will just say, though, that most family doctors have ordered and do order Lyme serology, but they haven't a clue how to order antibody testing against the other infections you can get from a tick. And I find those quite useful, because if somebody comes back and they've got Rocky Mountain spotted fever antibodies and or anaplasmosis antibodies or Bartonella antibodies, or rarely babesiosis antibodies, which is the kissing cousin of malaria, the only way you can get those infections is to have been bitten by a tick. And in Ontario, roughly 1 in 3 ticks now have Lyme. 1 in 8 have babesiosis in them. And probably in the order of 1 in 25 or so have anaplasmosis and some of these other rarer infections. Rocky Mountain spotted fever, anaplasmosis, ehrlichiosis, Q fever. These are what are called rickettsial bacterial infections. And so ticks are horrible in a way as vectors, because they can carry bad bacteria, bad parasites, which is babesiosis, a red cell parasite, just like malaria. They can carry Lyme disease, obviously, is the bacteria, but also viruses. So the one virus that's got a Canadian context here is Powassan from Powassan, Ontario, which is, if you get it, quite fatal, actually. So it's not that common, but ticks can carry that too. So nothing good comes from a tick. And you're just lucky if you get a tick bite and you don't get one of these infections. Some ticks carry all of those at once, which is also frightening.
Very frightening.
So if you have Lyme plus co-infections, those folks are the ones that are the sickest overall. Even if your immune system's pretty robust, if you pick up Lyme and babesiosis and anaplasmosis or Rocky Mountain spotted fever, if you get a whole kit and caboodle, you're in bed and not getting out, and you're now on long-term disability, and that's a whole other story because now they can't afford to do any testing or treatments often.
Right. You've helped with a very complex situation. Your descriptions are so vivid, and I'm sure resonate with a lot of our audience.
Sadly, that's likely true.
But I think you've been informative about new ways to head, and that's an important feature. I mean, people like you are being persistent with recommendations that make sense to a lot of the lay people.
Thank you, Kim. The last comment would be, because we get called almost daily, even in wintertime, if the ambient temperature is over 4 degrees Celsius, ticks are active, mobile, and can still transmit disease. And of course, with global warming, our winters are, I remember as a kid in Toronto growing up that Christmas was always white. You know, there was always cold and snow. And now it's kind of 50-50 if you're going to have a white Christmas. So we are seeing global warming, and we're having more ticks and tick bites year round almost. And so one point is, if you get a tick on you or on a relative or friend or your dog, and you want to know what's in that tick and whether you need to do something about it, you can send it to public health. They will take about 6 months to process it and let you know, which is not very helpful. But you could also send it to a good friend of mine, Justin Woods, who is by training a molecular biologist. He started a laboratory called, very cleverly, Genetics, TICKS on the end. Yes. He will be speaking at the conference. To his great credit, he's provided this service to anybody in Canada to send a tick in, put it in a Ziploc bag, courier it to him, and within typically 48 hours, he will turn around an analysis of that tick, what it is, and what was in it, using very sophisticated PCR, polymerase chain reaction, basically DNA fingerprinting. And so that's helpful to decide whether you need to be on treatment. But for many people, one of the things to be aware of is that Lyme, especially in the community, is starting to be resistant to antibiotics, or more resistant than it was decades ago, much like other bacteria, and that the conventional emerge doc primary care approach of, oh, here's 1 or 2 tablets of doxycycline, that'll do it. No, it won't. Here's doxycycline for 2 weeks at 100 milligrams twice a day. That might be helpful. It has about a 50% failure rate. So if you want to play roulette and maybe get chronic Lyme or maybe not, then okay, take that. I typically would respond that although the antibiotic is not pleasant to be on at double dose, if you want to increase your likelihood of avoiding chronic Lyme illness, take 200 milligrams twice a day for a month. Especially if you have developed an actual bullseye rash, because erythema migrans bullseye rash means the Lyme bacteria is in your skin. So it's not a question, it's definitely there. Or if you send off your tick to Justin to Genetics and it says there's Lyme in it, and it was on you for even minutes, because this is another mythology, and it has to be on you for 24 hours before it will pass the disease. No, it could have been biting another animal, a deer, because they like deer, for 23 and a half hours, and then it jumped off the deer and got onto you for half an hour, and then it spits up its Lyme. They've done research showing that Powassan virus can transmit in 15 minutes. Lyme disease is anybody's guess. So this whole mythology that you can't have Lyme if the tick wasn't attached for 24 hours, and you can't have it if you didn't have a bullseye rash, that's all BS. Many of my patients have Lyme for sure and never had a rash and didn't even see a tick. So these criteria that have been used out there are to be discarded and rethought. And I definitely in the acute Lyme world err on conservatism of using higher doses of antibiotics for longer periods of time to make sure you're because chronic Lyme is a much more difficult thing to deal with.
Mhm. Dr. Cook, in wrapping up, what are you hoping are the outcomes for the conference?
Well, again, this is a tip of the iceberg approach at educating and helping my fellow physicians and medical practitioners identify patients that they are almost certainly seeing on a quite regular basis that have this disease and are not getting the diagnosis and or getting the care to reduce their suffering. And at the end of the day, if more people have this knowledge in the medical system, it will reduce a lot of suffering for our patients, but also, as mentioned, the cost that these patients are bringing to our health system will be reduced if you get to the diagnosis much faster and you get them on treatments that get them functional and back to normal much faster. So at the end of the day, I'm hoping this will be successful in educating a larger swath of our primary care medical practitioners and ultimately then have a beneficial impact on our health systems function and cost and reduce suffering for patients, which is what most doctors are meant to be about.
Thank you very much. You have been most informative and I'm sure are going to be welcomed by all of our listeners.
Thank you, Kim.
Thank you for listening to this episode of Looking at Lyme. Tune in next time to hear from more experts from Canada and around the world. And remember, don't bring the outdoors indoors. Check for ticks.